Good morning, doctors. This is N.K. Prasad welcoming you all for today's webinar. On behalf of Indian Dental Associations, our gratitude to Synergy Specialist and RF America for sponsoring this 7-part CE series. Thank you very much. Just to go through the program for today, we will have the webinar starting in about a couple minutes. That at the end of the webinar, which is going to be to approximately take 1 hour, meaning around 11 or 5 after past 11, we would like to invite our sponsors, Darius from Synergy Specialist, and also we'll be inviting Tim Todak from RF America. They'll be talking about the service and products. That should take approximately about 10 minutes. Then we will open up for question and answers, and we will wrap up everything around noon time. 2 units of continuing education would be provided. I'm very much honored to introduce the speaker for today, Dr. Shervin Molayem. He started as usually a Bruin. He did his undergrad and he completed his dental school, but he ended up as a Bruin. He did his perio program at USC. He's the founder of both UCLA and USC Journals of Dental Research, which have been going on for 13 years, which is it's just excellent. He has lectured and conducted research in the field of dental implants and is the co-founder of Synergy Specialist, the largest agency for traveling dental specialists in the United States. Dr. Molayem has been in private practice in Southern California for the past 10 years. He's also a traveling specialist. Since the pandemic began, he has spent much of his time doing research and has an article being published in few weeks at the CDA journal on the mouth COVID connection. Dr. Molayem, warm welcome to you and all yours, doctor.
Thank you. Thank you to the IDA for having me and Synergy Specialist to do this 7-part series. This is the first. Could everyone hear me well? See me well?
Yes.
Okay, perfect. So a little bit about myself. I'm a specialist myself for the past 10 years, and it's a great setup for a specialist. I work with Darius from Synergy Specialist. He's my partner, and just wanted to say thank you guys Thank you to Dr. Rana. Thank you to Minal. The IDA has really done a great job of organizing this, putting a lot of energy. I've seen a lot of emails back and forth. They're working really hard for its members, and it definitely shows. I want to talk about a really important topic. This is actually from the research that I've been working on. This will be the first time I'm presenting it, and I think it's actually going to make a huge impact on dentistry and what's going on in the world, because it's going to be the first time that as a dentist we have a real power and opportunity to treat a patient in a holistic, very much like a doctor. It's not just dentistry. So we have to look at the whole mouth, the body, and how everything is connected. And especially now with the pandemic, I'm going to relate it to COVID. And a lot of the things I'm going to be talking to you about, I've been practicing and doing and talking to patients about, and patients love it. They love hearing about it. They love the fact that someone cares and is telling them this information, because most patients aren't going to see their doctors right now. The only times they might, go somewhere is to the market, to, do run an errand, to the bank maybe, and maybe to their dentist. And some people are even avoiding that. So it's our job to step in the shoes of the medical doctor a little bit more and educate them on present day care and their mouth and what I'm going to be talking about. Okay, so let me pull up my presentation. All right, so the topic is basically the mouth-COVID connection, and in particular, it's IL-6 levels in periodontal disease and its potential role in COVID-19 related respiratory complications. Before I get into this, I felt that from this lecture, I want you guys to be able to take home into your offices something that's very, very valuable, and that's how to explain everything to your patient. Because if you hear something I say, it could go through one ear out the other, and then you won't be able to verbalize it, then I haven't done my job. So I'm going to talk about periosystemic a little bit in the beginning, how to describe things to your patients. We'll do a little role play, and then I'll get into this topic so that you have the mindset of, when you're hearing this, how am I going to be on Monday, tomorrow, be able to translate this information to my patients. So first, you want to be able to talk about gum disease, but you have to do a comprehensive periodontal examination. So you have to do, full mouth perio probing, and I'm surprised how some dentists may not do this, and it's very important. The periodontics is the foundation. You have to know what you're building on. You have to know if there's termites underneath this house. So we want to know what's going on, how deep. We want to identify pockets with bleeding on probing and 5 millimeters or higher initially, and then check it 1 month after SRP. So if you just do, scaling and root planing and it's not checked afterwards, then, the 7 might be a 6 and it's still bad. The 7 millimeter pocket might be a 6 millimeter pocket. And also, we want to show them the areas in the radiograph where they have bone loss. How do they know what an X-ray looks like? They don't. So we have to show them. In order to see a problem, we want to first show them an area that's healthy. So you point to interproximal bone of number between 28 and 29, and you show this bone that's really, really white at the top, and how it's black and white between the gum and the bone, and how bacteria hasn't entered into the bone. And so you say the whiter it is, the more dense and strong this bone is. Then you point to the area where they have a little bit of fuzziness or grayness in the x-ray, and you say this is bacteria that's starting to penetrate and deteriorate the bone that holds your teeth. So they have to see it. So x-ray, they have to see it on an x-ray, and then they have to look at it in the mouth. So I hand them a mirror, a patient mirror. I put it in their hand, and literally we're looking together. I then show them in the mouth an area that is not, the area that has like a 2 or 3 millimeter pocket. I usually go to the front and show them how the probe barely goes in. And then I'll go to the area in the back usually that has a deeper pocket, and then now they see that the probe fall in, and sometimes 5 millimeters, 6 millimeters, 7 millimeters, whatever it is. And if there's blood coming out, I show them and I tell them, look, there's bleeding, there's hemorrhaging of the gum, which is a sign of disease. And the last 2 points of showing them is really key, because then when they see it in their own mouth, when they see that they have it, it's not just someone telling them that they have it. They start to own it and feel like it's actually them that has it, which is very important. Could you guys hear me well? Everything okay so far? Yes?
Perfect, Sherv.
Okay. So then you want to explain what stage they are in the disease. So they're just sitting there now looking at you, and they know they have some issue. So they want to know, is this an extraction? Is this person talking about a cleaning? So you want to give them an idea. So, early, moderate, severe, hopeless, you want to kind of give them a range. You're somewhere in this range, and it gives them some sort of idea. And then you want to start to explain what's going on. So this is, and if you guys want, I also have this in a PDF format. I could send you all of this. So basically, I'll say the teeth, and by the way, what you think is obvious may not be obvious to them. So they may not know teeth are held in the mouth by the jawbone. So I have to kind of set the stage that your teeth are held in your mouth by this jawbone. And one of the dirtiest parts of bodies is our mouth. There are over 100 million bacteria on a dirty surface of a tooth. Okay? These microscopic bacteria, they may leak between the gum and the root and into the bone, thereby deteriorating the bone. This infection softens the surrounding bone and can cause the tooth to become loose and it is an that I don't understand anything other than infection. Exactly. No infection. If you still don't feel like they don't understand it, and when you want to look to see if they understand it, you have to look at their body language, their face. You want to look at how they're if they're nodding when you're talking to them. So if you kind of just get a blank stare, then you have to explain more. So I'll use a metaphor, and I'll go, well, this is similar to the wood, the bone that you have around your teeth is similar to wood. It's porous. And the bacteria, they're similar to termites. And this termites can go in and bring wood or your bone. And similar to this wood, this process is usually painless and quiet. So a house could have termites for years and they wouldn't even know. but gradually it's spreading into more, unaffected areas, and so you still may get the donor, because some people only understand pain, and they only come in when there's pain, and that's it. So then you have to tell them that there's not much nerve endings in the gum or in the bone. The main nerve in this area is inside the tooth. That's why that's why root canals hurt so much, because that's where the nerve is. But in the gums or in the bone, there's not that much nerves. That's why it's a silent disease. And only 6% of actual gum problems cause people pain. That means 94% of the times where people have infections in their jawbone, most people don't have any pain. So now now they might be doing a little bit more nodding, and they're engaged and they're listening. So I'll go into a little bit of, sometimes I'll talk about how, if it depends on their age. So if they're like in their 30s or 40s, I'll talk about how the first third of our life, the bacteria in our mouth are the ones that mainly like to attack the tooth and cause cavities. Then when we get into our 30s, the bacteria starts to shift and change composition to become more of a different type of bacteria, an anaerobic bacteria. These are bacteria that can survive without oxygen, and they go underneath and start to attack the gum and the bone. And then I'll say the way the bacteria get into our bloodstream is by leaking the gum and bone around, surrounding the tooth, and then entering into our heart and other organs. It spreads in our bloodstream. And these have been linked to higher chances of heart attacks, 2 times higher chance of stroke, arthritis, diabetes, and even Alzheimer's, because of the bacteria P. gingivalis has been very highly linked to Alzheimer's, and 5 different types of cancer, and one of them being pancreatic cancer, which is the worst one of the cancers. Females have a higher chance of getting breast cancer. Males have a higher chance of erectile dysfunction. On and on. So many different connections. But sometimes I'll say, to give them an analogy, I'll say the bacteria, the blood in our gums and in our mouths, that same blood is going to reach our foot in 1 minute. And then they do like a little wow. That's why we have 60 beats per minute when our heart is pumping, and tell them when you feel your pulse going boom, 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 and making that noise, your heart is beating and putting pressure and pumping this blood or circulating it around your body, and all it takes is 1 minute for the bacteria to flow. That means bacteria from your mouth is reaching your foot, is reaching that hip replacement surgery area that you had, everything. So now they really understand it. And you want to let them know there's no cure for this, but there's a treatment. And we can stop this. And in some cases, we can even regenerate what's been lost. And then they're going to say, okay, so what do we got to do, doc? What should we do? You say, well, we want to remove this infection from your body to decrease the inflammation in your bloodstream. We want to, therefore, lower chances of any systemic issues. And as a result, we're going to stop this bone loss. And, you'll be able to chew longer, keep your teeth longer. The research shows that the longer we keep our teeth, the longer we live, the more enjoyment we have when we chew. This also affects breath. The less bacteria that release sulfur in the bone, the less bad breath we have. That's where bad breath comes from. Most of it is in the top layer of the bone. Some of it is a little bit on the tongue, but most of it is there. So that's important to talk about. Then, depending on where they have the issue, you sometimes might want to point out where it is. So if it's next to the sinus, you might want to say, you're a few inches away from, it's right up against your sinus. You're a few inches away from your eye, your ear, your brain. There's a lot of important things in this area, and you point to where it is. It's a couple inches away. So there is a sense of urgency on a number 3, number 4, number 2 area, and if it's on the mandibular posterior, for example, you have the inferior alveolar canal, and there has been reports of infections getting close to the inferior alveolar canal and causing paresthesia, anesthesia, and issues with the nerve. So I started with this because I want you to have a frame of reference of how to talk to your patient. So the information that I give you, you can put into what I'm saying, because it's related, but we're going to take it one step further. So the presentation I'll be giving is based on this article that was accepted to the CDA journal. It will be, they're making a special COVID edition, and this is going to be one of the featured articles, and they're looking for either September or October issue, but it will be released in digital, hopefully in a couple of weeks, but you guys are getting it first right here. So the IL-6, so what's our current knowledge, basically? We kind of want to break down where we're at right now. So with COVID, let's start with the big picture. We have a disease that basically, of the people that get it, 80% have mild cold symptoms or no major complications. So it could be, asymptomatic, just nothing major, 80%. So it's a good majority. The 20% have severe symptoms. So usually severe symptoms since this is a respiratory disease, usually they're respiratory problems. And then 5% are life-threatening, meaning they need to be in the ICU, they may need to be intubated. But what causes this downhill progression is linked to IL-6. Okay, this is a very important name to know, because IL-6 or interleukin-6, which is a cytokine, and part of the cytokine storm, a study from Germany that I will talk about shows that it can predict respiratory failure and the need for mechanical ventilation in hospital patients. So the different ways that it can get transmitted is in the oral cavity, salivary glands, saliva, and we want to definitely use very good, as dentists, good infection control, a lot of PPE, and basically just be really careful to protect ourselves. So the approach that I want you guys to start to get, at least for this year, 2020, is you got to put on your doctor hat. You got to put on your, not really scientist hat, but just doctor hat, so that you can approach health, the entire health of a patient. And I've been doing that, and it's been working. Patients love it. They, I jot down, what they should be doing, how to stay safe, tips on how to survive and live longer, and I'm going to go over all that today. So definitely take notes on this. So we'll talk about periodontitis, which is, different from gingivitis. Gingivitis is more in the gums, is the inflammation of the gums. Periodontitis is more in the bone. So when you get the grayness, the fuzziness in between the intercrestal bone between teeth, that's periodontitis. When you have 5 millimeters or more pocket with that's periodontitis possibly, with a little bit of bleeding, And right now you want to be a little bit more aggressive with this, especially in elderly patients. And as a result, this is all going to decrease the inflammation and cytokines and decrease IL-6 levels, which will therefore decrease the severity of respiratory complications. And we'll get into that. So in terms of periodontitis, there's really 4 kind of pillars. The impact of the connection between periodontal treatments, IL-6 levels, respiratory conditions, and COVID-19 can be powerful considering a high prevalence of periodontal disease. So periodontal disease is, periodontitis in particular, is in 47% of American adults. So almost half of all adults have a mild, moderate, or severe form of periodontitis. And in adults that are 65 years or older, it's 70% have it. And lo and behold, these are the population that are dying from COVID the most. Also, we're looking at the limited access to periodontal treatment during this pandemic. So there's offices that are still closed till this day. There's offices that haven't opened. I don't know if you guys are aware. There's people, the elderly, the baby boom dentists, a lot of them are just, they're more careful, some of them, and they haven't opened still. They're waiting for maybe a vaccine for a couple more months. I don't know. But there's a shortage of dental hygienists. I'm in the Facebook, the chat groups, and someone asked, is there a shortage of hygienists in your state? There was 140 comments of people from every state saying there's a shortage in my state, there's a shortage. Hygienists are freaked out. They have their own Facebook groups. They're talking about how there's a shortage of PPE. I was going to say PPP, that too. There's a shortage of PPE, and they're scared. They heard that this aerosol hangs out for 3 hours in the operatory afterwards. So even if they have 2 operatories, they can't go one room by one room, and they've just been, we have, our doctors and dentists, we have our own chats where we talk. They have their own, and people are definitely scaring them because hygienists have been very late to come back into this. And there is a shortage. There's people shuffling around, people moving to different offices, closer home. There's opportunities. They can get paid more as well. They see, some of them that are smart, they see it as an opportunity, and they can go to a better location at this time because there's openings. I called myself the other day in Southern California, 10 dental offices to find out when is the first time I can see their hygienist, and the average was about 16 or 17 days to see a hygienist. So it's about a little over 2 weeks to get to a hygienist, because there is a backlog of all these patients. If they're seeing 6 or 7 patients a day or so, it's adding up to a couple of weeks wait right now to get a cleaning. So all of this plays into the effect of what's happening in people's mouths, because now people's mouths are dirtier than ever before on top of everything. So I wanted to go over what's happening with COVID today, and this is the average case, daily case that you see in the US, and this is the 7-day average line, which is whenever you look at a chart, this is the line that you want to look at, because this is where we can determine trends from the 7-day average line. I always look for that line. And you can see there was, you know, in the beginning here, you have, let me get my pointer here. Here. In the beginning, you had this big boom, and then now it's going up. Now, one might say that there's more tests. Well, that's true. There are more tests, so that's why this is going up so high. So this may not be the best way to see what's going on. Hospitalizations are a little bit more of an accurate way to determine. And you can see even hospitalizations are pretty high again. So we're definitely in the US, there was one wave, and then this is the second wave. But we've been warned about this. In 1918, there was a second wave, and you know, people let their guard down. We had the protests that coincidentally, you know, happened somewhere around here. So we basically are in a bad state because, you know, this is a real disease. People are dying, and we do have to be careful. Although it is less deadly than previously thought, so that's the good news. The death rates are lower than what we thought, and they're talking about numbers such as you know, 0.3 to 1% death rate, which is much less than what they originally thought in their models. So we are back here right now, starting to rise with some deaths. Treatments have gotten much better, and I'm going to talk about treatments with this. So that's some good news. We are getting better at treatments, and they are working on vaccine. Now, let's talk about IL-6, and I will try to go through this a little bit fast. So IL-6, again, it's a cytokine. It's an inflammatory molecule. And in general, periodontitis is an inflammatory process. It results in a destruction of our periodontium, and it triggers an immune response due to this biofilm. Basically, it all has to do with that biofilm. That's where the bacteria live. Cytokines, when you hear about cytokine storm, cytokines are soluble proteins. They're proteins. And they're basically cell mediators. They're signals. So they tell other cells what to do. You know, it's like basically when our body gets an issue, our body soldiers come to attack, and then they sound the alarms. You know, they ring the bells, and they send these to go and recruit and do a lot of other things. Some of them are good, and some of them are bad. Some of them can cause injury to us. We're going to talk about that. Of IL-6, there's different types of IL-6, and these are just kind of like polymorphisms or changes in the nucleotide, but I don't want to get into it too much, but there are different types. There's two main ones that we you know, the majority are two. Now, I want you guys to pay attention to this. This is important. In the IL-6, in the gene, remember, with genes you have two alleles. Okay, you have like with IL-6 you have two alleles. You have either the C or the G. Okay, so you can be a GG, a GC, or a CC. Now, C is good, G is bad. So, for example, if someone is a GG, it's bad. If someone is GC, it's medium. And if someone is CC, it's good. Meaning you're less likely to have an abnormal reaction when you get an infection, or you're less likely to get, you know, certain diseases and inflammatory diseases and arthritis and things like that. So so basically, this IL-6 is produced in gingival or blood cells, and it can cause bone loss. Okay, so locally it happens in the gum. Okay, so in the gingival and the gum fibroblasts, they produce it. Then it goes down to the bone, where it can cause, it stimulates osteoclastic activity. It inhibits osteoblasts, so it definitely causes bone loss. It's IL-6. And then the release of MMPs, which is something that breaks down collagen, it causes tissue destruction. So it's not a good thing for us. This is one of the worst, IL-6 and periodontitis. Now, this is the 4 kind of reservoirs where it hangs out. IL-6 likes to be released in these places. And it's basically, I want to just go over 3 of them, brush over, and then we're going to talk about serum. But in the gingival crevicular fluid, that's the little fluid that's inside the pocket, the periodontal pocket. It's in saliva, IL-6, and it's in, and that's why one of the tests to find out if you have, the IL-6 gene and whatnot is a spit test. So, and then also it's found in gingival tissues and in serum. So, serum is basically blood without the fibrinogen or the clotting factor. And keep your eye on these numbers. So when IL-6 goes higher than a certain number, I'm going to show you later that's what leads people to go on a ventilator. Okay, so I don't know if you guys are catching on the connection, but it's being touched up on right here. So IL-6 from periodontitis leaks into the blood, and in periodontitis patients, it's in this range, and up to 216 has been even shown. Okay? There's a lot of evidence for this, so this just kind of goes over that. So we're going to be talking about some of the genetics, the cells. So let's get into that. There is a strong evidence on the key role IL-6 plays in the immune system and on bone resorption and periodontitis. And the genetic studies confirm IL-6 polymorphisms can be increased the susceptibility to periodontitis. And in vitro studies confirm IL-6 can be produced by a variety of cells. Okay, so it's not just like one cell is releasing this. This is released by macrophages, neutrophils, T cells, B cells. Almost all of our body soldiers, so to speak, are releasing IL-6 versus some of the other ones are just released by a couple of them. This is everyone could release IL-6. And periodontal treatment could lower this. So just by getting, and I'll get into that, either cleaning, SRP, osteosurgery, certain oral hygiene regimens. Our goal as dentists is going to be looking at how to decrease IL-6 levels in people's body. Also, we're talking about, again, periodontitis, but there is IL-6 also found in periapical lesions and pulpitis and in periapical radiolucencies. Those lesions when they do sampling and they are finding it in there, and they're just finding this stuff out. So they haven't really been testing this last one too much. There haven't been that many studies on it. So they're finding this out now. So if you have a root canal that's going bad, or you have a root tip that's been left over, and you're seeing some grayness in the bone, all of this is increasing IL-6. We have to have our radars high right now for this particular thing. Our patients will appreciate you for it. We're going to talk about some respiratory diseases, okay, and periodontitis, and why that's in there is because there are many respiratory diseases that are worsened by periodontitis, and it's a lot of research on this. And respiratory diseases we're talking about because that's how people are dying of COVID. So COPD, there are lots of studies on this, but basically there's a huge association, and there's a higher prevalence of periodontitis in COPD patients. There's fewer teeth in people with COPD, and there's more inflammation in their gums. And with pneumonia, you have a significant association between pneumonia and poor oral hygiene. And in the studies, antimicrobial interventions decrease incidence of pneumonia. And so we want to do comprehensive dental care on them, and especially with pneumonia, because remember, this is how people, when you get the cytokine storm, you're in the hospital, and there's people that are dying. It's pneumonia that at the end that's getting them. So if there is a relationship between periodontal disease and directly what's killing people from COVID, you have this direct relationship with pneumonia. So especially in hospitalized patients, I feel there should be some sort of look at their gums. There should be some dentist going around checking these people to help with everything I'm talking about: lower IL-6, help decrease respiratory infections, and whatnot. And also, periodontitis and lung function in general. People who do get, again, these are all the articles that cite what I'm talking about. There is a connection between improved lung function after just, cleaning, taking care of their teeth, their gums. Asthma as well has been linked, and gingival inflammation, and also potential confounders are use of inhalers, and the fact that they do a lot of mouth breathing and they have lower saliva. So these are possible potential reasons why for asthma in particular. So to kind of just summarize a little bit, we have periodontitis. It affects COPD, lung function, pneumonia, in particular for COVID. Periodontitis and poor plaque control can affect respiratory complications in COVID patients, and COPD is a risk factor. With severe COVID means basically when they have we're about to get on a ventilator and they're in the ICU. So that's a great place to and frankly, I would like to see if I'm going to reach out to the hospital nearby me, Cedars-Sinai. I would like to even see if I can volunteer and go and maybe do a study or go check people's gums, do a cleaning, and just who are in the ICU. That's I was talking to my wife about it actually last night. I think that would be something that I can do to kind of help out, knowing this information. So now we're going to talk about IL-6, viral infections, and COVID in particular. So we're going to tie it together. So again, we have the 80% mild symptoms, 20% severe symptoms, 5% that are on the ventilators, possibly. The risk factors are age greater than 70, respiratory disease. So if you had a respiratory disease in general before, diabetes, cardiovascular disease, and cancer. So these risk factors that you see here, these are when you hear on the news, oh, you know, people who have already health problems are the highest risk. So these are the risk factors. And I don't think it's a coincidence that if you look up, if you Google which people have higher, what makes people have higher IL-6 levels, like in the population, what are the IL-6 levels that are the highest, which diseases? It's these. So naturally, aging, you get more IL-6. With diabetes, you have higher IL-6. With cardiovascular disease, you have higher IL-6. Obesity, you have higher IL-6. So I don't think it's a coincidence. I think there's definitely something there. And this is, you know, the ACE2 receptor is where the virus binds, and those receptors are in the lungs and the epithelium of the nose, mouth, and lungs. So that's why the virus goes into these places, because that's where the receptors are. Let's go to the next slide. And this what leads to the cytokine storm, and it could worsen. High IL-6 levels can worsen alveolar capillary blood gas exchange in the lungs, contributing to fibrosis and pulmonary failure. So there is, so IL-6 directly, there's a direct link between that and getting into the lungs and causing this as you see in this blue box, the fibrosis. So the chest X-rays that the doctors take, and they see the glass-like appearance. I don't know if you guys have seen the lungs on the X-rays. Part of it is from the IL-6 too. So there's so many different ways that it's connected, this IL-6 to what we're, and we are connected to that IL-6. So we, in a way, dentists, we are connected to saving lives at this moment. And you'll be surprised how little patients know about this. I've been talking about this for the past 2 months. Almost every patient, they have no idea. I go, do you know that people are dying of inflammation? They're like, no. I go, do you know what IL-6 is? No. Do you know what cytokine storm is? No, never heard of that. Everyone, I don't think there's been one person that says they know what cytokine storm is. They should know what's killing people from COVID. And so they really appreciate when you tell them. You're going to give great value for your office, for yourself. They're going to look at you like, wow, this was the person at the end of the day, out of everyone. The news didn't tell me anything. My doctor didn't tell me anything. My dentist told me what was the key, how to live and how to survive and what to do. That's why I think this information is so important. This is a very important slide. So pay really good attention to this slide. I show this chart to a lot of my patients, put it that way. This was the slide or the chart that sparked my interest in all this. This is very dear to me, this study. And I actually contacted this guy, Tobias Harold. He's a doctor in Germany. And they did a study. It says July 2020, but actually it was done and released digitally in April. So I had looked at this and I had seen this maybe a week or so after it was published in middle of April. That's when I started my study. But basically, they show that elevated, so it's very beautiful, brilliant, simple study. They took people in their hospital who were on a ventilator, before ventilator, after ventilator. They drew their blood, and they wanted to see what's going on in their blood. Let's see if there's anything high, anything low, what's going on. So they map out all of the different cytokines. They see high this, low that. They see that every time someone goes on a ventilator, almost every time, in science, these are called outliers. So with outliers, you scratch them out. And they even cancel each other because there's one on each side. But there's a clear line of the people who go above 80 on this, their IL-6 level goes above 80 pg per milliliter. When it goes above, they go on a ventilator. When it's below 80, no ventilator. They live. Of the people that go on a ventilator, 80% of them are dying. So this line is 20% away, from almost life and death. So it's almost, you can say, keeping your IL-6 level below 80 is almost life and death right now. So the study showed that high IL-6 levels predicted respiratory failure, 22 times higher risk for respiratory complications. And by respiratory complications, I mean ventilation, intubation. That means you're not breathing. A machine is breathing for you. Let me go back to this. 22 times higher risk. Okay? Just think about what that means. There's studies that show it's 3 times higher. Like, wow, 3 times higher? 5 times, 10 times higher? 22 times higher. Which means that the conclusion was that they used the word predict. High, that's a key word. In science, there's a link, there's a cause, there's a trend, there's a connection. This is so strong, they're saying that it will predict your living or not. So I'm going to be talking about some other studies and treatments that are being done right now as well. And one of them here is very, very interesting. So tocilizumab is an arthritis medication that's currently available. And it's an IL-6 antagonist. So it will not it binds to the IL-6 receptor, and it doesn't allow it to get absorbed as much. So now you can decrease IL-6 levels by just taking this drug. And according to this study that was in pretty much May, 90.5% of patients recovered after an average of 13.5 days. That's pretty high. So it makes sense. If IL-6 is the main thing that's bad, this is a cheap drug that already exists. By taking this, you can get a pretty great result, great recovery. All right. So I really like this one because this makes sense. IL-6 is bad. Let's stop IL-6. We have a drug that does that. Let's try it. Works pretty damn well. Then this is another beautiful article that I'm sure you guys have heard about that talks about dexamethasone, or a steroid that and I want to talk a little bit about steroids because I think this is really important. So when dexamethasone or Decadron, it's a cousin of prednisone, a cousin of Medrol dose pack. This is all in the same family. When people were in pretty bad in shape, they were in the ICU on a ventilator, When they were given dexamethasone, it reduced the chance of dying by 1/3, 33%. That's pretty good. That's not a bad thing to know. Now, the people that were receiving oxygen, those people was decreased by 1/5 or 20%. So this is a great understanding. Why? Because steroids are anti-inflammatory. They decrease inflammation. They decrease IL-6. They decrease CRP. And remember, the other study also, I didn't talk about it too much, but CRP also is a predictor. CRP. These are inflammatory inflammatory proteins that are bad and are linked to a lot of autoimmune. Actually, a lot of autoimmune issues are from CRP. Now we're going to talk about this one. I love this because dexamethasone in the slide before was taking oral pills, steroids. There is a doctor from Texas that in his hospital, he tried a nebulizer of steroids. So a nebulizer is one of those masks that you put on your nose and your mouth, and you breathe in oxygen, you breathe in whatever drug they want to give you. Okay, it's an inhalation. You're inhaling. So what he did was he gave all of his patients in this hospital, the ones that he wanted tried it on, to inhale the steroids. Now the difference is, he was saying actually the way he described it was, and his son is a firefighter, so he described it very nicely. He said, if you have a fire that's out, that it started, he's like, do you want to wait until the fire spreads? Yeah, then you can give dexamethasone, and you're giving it generalized for everything. But why not catch the fire at the source? And where is the source? The source is in the nose, then the source is in the mouth, and because those are where those ACE receptors are. Why not? Let's inhale the steroid. Let's decrease inflammation there so that it doesn't spread and go into the bloodstream from there. He says that not one patient in his hospital has died yet from COVID that he's treated. Now there's other articles coming out. So there's current evidence, there's ongoing studies. They're trying, he did it with budesonide, which is, these are they're asthma medications that you inhale. So there's studies now happening on this. And I told my former professor, my former program director, perio program director, was at PhD. I told him about this. He contacted, I didn't even tell him to do this. He went and contacted another doctor at the hospital that this guy was at to see if this was true. I don't know if he knew the doctor or if he just said, I'm a doctor. I want to know if it's true. And the other doctor confirmed it too. So this is very promising. So we have the cytokine storm that happens, treatments, and inflammation, the sources of inflammation, kind of the summary of what we talked about. Now I want to just go in a little bit into the biologic mechanism. So how is this actually getting into our bloodstream? How is it getting into our body? How is this affecting us? So this is how kind of how inflammation works. This is how systemic inflammation works. So you have this bacteria, it gets in from the biofilm. They release toxins that get into the blood, get into the gums, and then this is part of the local production. So you get an increase in IL-6 locally, And then you have the late response. Then you have your cells that come and fight it. Remember, the T cells, B cells, macrophages, neutrophils, they all come in, and they also release IL-6. Now, then this IL-6 gets into the blood, and it starts swimming around the blood. And then you have, I'll talk about it later. I wanted to see if it was next slide, but it wasn't. Then you have other things that activate it further, okay? But this bacteria causes bacteremia, and it upregulates other inflammatory mediators. So this is like that's why they call it a cascade of inflammation, a cascade of events that one leads to another, and the other one releases more IL-6, the other one releases all throughout the body. Things are, everyone's sounding the alarm and releasing this IL-6. There's also, remember, in the bacteria, in 1 millimeter, 1 cubic millimeter of oral biofilm, there is 100 million bacteria, or they call it also in one dirty surface of a tooth. I said it earlier in my explanation. There is 100 million bacteria. Now, this bacteria, it could get aspirated, so it can get into the lungs and cause issues that direction. There's gut we'll talk about that. And then there's the enzyme route. So enzymes produced in periodontal disease can alter the surface of respiratory epithelium and also facilitate the adherence of respiratory pathogens. And lastly, the cytokines can modulate bacterial adhesion of pathogens to the pulmonary epithelium. So literally there's a direct link here between bacteria and these cytokines and pulmonary epithelium, lung epithelium. There's not only are they doing things with IL-6, they're going in doing things through to the lungs themselves directly. Now, let's go to the next slide. So gut dysbiosis. So gut dysbiosis means there's an imbalance in the bacteria in the gut. And this happens via swallowing of saliva. Okay, and this is why, everything's all linked. The mouth, it's the mouth-COVID connection. Everything is linked. And as a periodontist, we get good training in immunology and infectious diseases of the mouth, gums, viruses. So when I was reading up on this was, a lot of the literature resonated with me. That's why I became so interested in this, and it's so relevant, I feel, to periodontists. And I feel like periodontics is definitely on the rise as a specialty. I've been much busier myself. I've been really busy the past couple of weeks. Just by talking about this, explaining this, and it is a good specialty to bring into your offices, because literally we do extractions, bone grafts. I take out wisdom teeth. I soft tissue grafts, osteosurgery. There's so many things that a periodontist can do that provide value for an office. So once this is swallowed, the bacteria is swallowed, the pathogens will then reach the gut. And there's also a bacteria that can withstand all the acids in the stomach and colonize the colon, which is P. gingivalis. And that's why there's a link between that and like colon cancer, for example. So and viral infections can promote the colonization of oral bacteria. So in health, oral microorganisms are poor colonizers of the GI tract. But when there's systemic conditions such as viral infections that are present, there's higher numbers of oral bacteria that have been identified in the intestines. And the changes in gut microbiota have also been suggested to play a role in COVID-19 severity in elderly patients, who typically present decreased diversity of the intestinal microbiota. These alterations in the gut microbiota seem to be shared characteristics of periodontitis and viral infections, particularly coronavirus disease, which potentially exacerbates inflammation and the severity of the complication. So this is, it's not only about cause and effect, but we don't want severe COVID to get exacerbated by these conditions. So endothelial dysfunction. So endothelium is the lining inside a blood vessel. So this is the same way that people get the atherosclerosis, the connection between periodontal disease and heart attacks and strokes is because the endothelial dysfunction gets out of whack and it's not able to dilate the blood vessels as well. Also, the endothelial cells are another thing that release IL-6 as well. So everything releases IL-6 when you have inflammation. It's horrible. This is a picture that I and my partner, Dr. Pontes, she's a PhD periodontist in South Africa, who is my co-investigator in this article, and we created this picture together showing a summary basically of the direct, indirect, and basically everything that can cause COVID problems. So if you look at the top, you start with some sort of stress, like a local inflammation of bacteria, right? So you have the biofilm stress here. That could either be aspirated, it can get into the bloodstream causing bacteremia, and then it can cause that cascade event. This literally goes in the bloodstream, the bacteria, and then you have the cytokines being cascaded and spread out through the body, and these are the ones that are doing it, IL-6 being the main one. There's a direct link, as we just talked about, with COVID. And that's a lot of what we talked about up there. Now we're within here, within aspirating, bacteremia, systemic inflammation, you have the lining of the blood vessels also releasing IL-6. And remember, there's blood vessels going to the lungs. So now it's affecting the lungs. You have the gut dysbiosis, the imbalance of the gut bacteria also affecting the lungs, we just talked about. Those are more of an indirect link with COVID. And all of this is increasing risk of complications with their lungs. So now we're going to talk about treatment, some treatments of what to do. So as dentists, we want to we're going to be seeing a lot more inflammation in our patients' mouths. We're going to see more bleeding. People haven't gone to cleaning in a while. Most of the people I've been asking, they're like, my last cleaning was a year ago. If I have their chart and I look, that year might be actually 2 years ago. They just said it was last year. Everyone says last year, you know. That's a good one. They always say that. When did you get that done? It was like last year. And then you'll look and it was like a solid 2 years ago, maybe even 2.5 years ago. But we want to, again, decrease IL-6 levels, decrease inflammation systemically. And given the high transmission rate of viruses and the 22 times higher risk for COVID of respiratory issues, every attempt to decrease this inflammatory mediator should be prioritized. So this should be like, step one when we see them. And not only are we helping for COVID, but remember, the risk factors for COVID are cardiovascular disease, hypertension, diabetes. If we treat their gums and get their gums healthier, then we're helping those factors that were increasing their risk to begin with. So it's a double whammy. And of course, good oral hygiene, which we'll talk about some. Now, patients right now, they're a little bit scared to come into the office. Some of them are seeing this in the news. They're seeing, these charts. We're working in patients' mouths. There's aerosol. They could be a little bit more on the scared side. But I actually think, with my research in this, in everything we've done, and we're showing that it is worth the risk of going to the dental office to get their gums treated because of the possible respiratory complications they can get from their untreated periodontitis. And at minimum, they can do a teledentistry. You can do some sort of screening and ask some questions and things like that, then get them in the door. So it's a kind of a baby step. The teledentistry is a baby step to getting them into the door, into the chair. But I am creating a letter that I will send to the IDA to send to all of you that will that you will send to your patients. It'll be like an email or a letter, however you want to do it, that explains this. That explains, hey, I know you may be a little bit apprehensive getting out of your house, but not coming to the dentist right now could actually harm you more than anything. And we're going to cite our article, and we're going to get patients into the office. So look out for this letter. Hopefully, it will be within this week that we can get it out. IL-6 genetic testing. I'm very big on this. So no one's talking about this. I don't think I haven't heard one person talking about this yet. And so I do a lot of bacterial sampling in the mouth, and remember the GG, the GC, and the CC. I work with this lab. It's called the Oral DNA Lab. They're very popular, big lab. And I talked to the owner. He said that of the people, you basically spit in a test tube. You send it to the lab, and they'll tell you every type of bad bacteria, pathogen that's in the mouth. They'll say, you could even tell them that you want to know if there's any risk in any of their cytokines. So they'll tell you what your particular patient's gene for IL-6 is. That's pretty important. It's not just for the mouth, it's their whole body. You want to know how their body is reacting to IL-6 when it gets released. When I found this out, I did it myself. I spit, I sent it. I happen to be a CG. I'm in the middle. So for what it's worth, but I get a lot of patients that are GG. And the people who have periodontitis, a lot of them that have GG. And when you look at their medical history, they also have a lot of other issues. Arthritis, diabetes, a lot of other things that we're talking about around heart medication. Of the tests that are sent to this lab, they had 12,000 tests. This is unpublished data, they just told me. 45% of their patients have a GG, 41% have a GC, and 13.8% have a CC. Again, it's skewed. The people who are sending to this lab, usually there might be an issue with them, so that's why it is on the higher side. We don't have a study to find out what the breakdown of our population is, which would be a great study. Anyone interested in doing any studies like this? I'm always, I would love help, and I always am interested if anyone wants. So this is a sample report of the lab from when they send it to me. Basically, it tells me, here, let me go to this page. It usually starts with this page first. That was the first one, was a summary. It tells you which bacteria are in their mouth. So we have, this one has AA, actinomycin, actinomycin, you know, the AA, the long name one. TF, Tannerilla forsythis. TD, FN, PM. So again, these are high risk. This is the worst. AA is the worst one. PG is very bad. That's the Alzheimer's, colon cancer, you know. And then these are moderate, these are low risk. When it goes above this line, this black line is the threshold where it's very pathogenic for them. So it tells you, you know, if they're close to that line, if they're at the line or above, and for which ones. And it'll tell you which antibiotics are good for that particular patient. So this is saying they take 500 milligrams of amoxicillin for 8 to 10 days and metronidazole 500 milligrams BID for 8 to 10 days. And usually this is done with at least an SRP, if not periodontal surgery, depending on their pocket levels. So if you do a SRP and they have a, you know, refer to your periodontist, they'll check it and they'll see if there's a pocket that's 5 millimeters or greater still, then I would do osteosurgery. All right. So now, what do these do? So if you look, these all affect certain parts of our body. So cancer, for example, AA, PG, TD, TF, FN, they're all linked to pancreatic, esophageal, colon, lung, and head and neck cancers. And then you have, again, cardiovascular health, these bacteria. So you can go through with your patient and say, well, you have TF, you know, this and that. So yours is linked to this and this. And since you have diabetes, you know, they may have diabetes and heart problems already, you can say, we got to do something about it. You know, your bacteria are high, you have already issues. Let's get your gums treated. Let's take care of this for your overall health. Let's decrease these numbers. Then they also can give you your IL-6 risk factor. If you have a GG, and G is risk, so there's higher chance of osteoarthritis, and overproduction of it has been implicated in systemic diseases such as chronic arthritis, rheumatoid arthritis, Paget's disease, and Sjogren's syndrome. So this is a good thing to get for patients. So it's like an action item. So solutions. So basically, we want them to, at home, do a lot of things. So brushing twice a day for 2 minutes. And, you know, I like electric toothbrush better than regular. Some people may need even more than 2 minutes if they're elderly and can't get in really well. But also rinses. So there's research that shows that betadine or povidone iodine rinse you don't need too much of it. Dilute it in water and rinse for 20 seconds, and it can kill all of the COVID virus amongst, back to all the, you can get a lot of the bacteria in our mouth down. So this is a really good one. Hydrogen peroxide rinse is also very good. For COVID, the iodine is the best so far shown. And you just need to put a few, it comes in at 10%, so you could water it down so that there's maybe a teaspoon or two in your cup type of thing. Professional cleaning. So these days, if I were you guys, your cleanings, I wouldn't do as much, unless they're like a young kid. I would do more of scaling. I would numb a little bit more. I would want to get a little bit deeper. I would want to get a little bit deeper if I can. I re-eval a lot of what hygienists do, and I see that you could either be a nice person when you're a hygienist, or you can be and get your patients to love you, or you can be the type of hygienist that gets the job done. Your patients won't like you as much. For the health of our patients right now, we need to be a little bit more, go a little bit deeper. If you feel like it's gonna hurt them, then either put some topical or numb them. It's okay. Put some topical and numb them, in the gums. Couple of, especially maybe in between number 13, 14, 14, 15. You don't need to numb their whole mouth. Usually we see more inflammation and pockets in the posterior. So maybe just numb in that area. So go a little bit deeper. You'll notice once you're cleaning, you're going deeper, you'll see more blood come out. That's good. Let the blood come out during your cleaning, because bad things are draining when it bleeds. And next time it'll bleed less and less. One thing on this section is, of course, flossing too. Twice a day flossing. And you have to teach them how to floss, so they don't just go up and down, but they're also wrapping around like a C shape in between each teeth, each way. So you can go mesially or distally in a C shape, like you're shining a shoe. So again, scaling, root planing, irrigation, laser if that's your thing. Refer to periodontist. I think this is key. Again, even better if you have one coming to your office. And evaluate their gums. The last thing is not the last thing, but the second to last thing is genetic testing, which we talked about. And then also they can get their blood drawn and find out what their IL-6 levels are and their CRP levels. So this is something that, again, my father-in-law, for example, he's a smoker, he has high blood pressure, he has all these things. I want him to do these things right away. Actually, I was telling him the other day, so that he knows where he's at. And virtual consultations and mobile dentistry. So I actually work with a company called Dentulu, and they do virtual consultations. They're getting into mobile dentistry. But if a patient is at home, have them download this app. It's called Dentulu, or they don't need to download it. They just go on the dentulu.com, and very easily they can contact you and talk to you that way. You can prescribe them medications there. It records the conversation. You can put it into their charts, all of that. Also, again, these are some things that people aren't talking about. Diet. So reducing inflammation in the body could be done with diet and anti-inflammatory foods. So less meat, more plant-based. Plant-based is like, for example, meat, like chicken, has inflammation, causes inflammation in the body. And also less sugar and less processed carbohydrates. So sugar and carbs are what increase IL-6 in the body. So you want to do less or eliminate those. And then, and again, these are all things I talk to my patients about. Almost every patient I talk to them, I say, what vitamins are you taking? You know, and they love it. They're like, Doc, could you write me down those vitamins you're talking about? They have no idea. So I tell my patients 5,000 milligrams of vitamin D a day, D3. Again, that's the most important, as you guys already probably know. Vitamin D is, if for example, someone gets COVID, you call a doctor, this is what they're going to say. They're going to say up it to 10,000 milligrams, but a good baseline is 5,000 milligrams. Also, 2,000 milligrams of vitamin C, 50 milligrams of zinc, and I like a turmeric 500 milligrams daily. Sometimes I'll even take 1,000 milligrams of turmeric, but that turmeric is a very good anti-inflammatory. Also, ginger, also onions, and also garlic are very good anti-inflammatory. So the take-home message here is that coronavirus disease is related to the cytokine storm. It's the high levels of IL-6 that cause a risk for mechanical ventilations or to get intubated by 22 times and is a predictor for respiratory complication. We have a systemic inflammation. There are certain genes for IL-6 that lead to increase our risk. We can get genetic testing. That this oral bacterial can be aspirated into the lung. It can go into our gut. It can cause increased risk for pneumonia, COPD, and potentially COVID-19 related pulmonary problems. And then what we can do, of course, is improve their general health. Those tips I just mentioned, improve their oral health, and therefore decrease their inflammation and IL-6. And we have the power to really impact, as dentists, now more than ever, their lives. So I kind of went over this already, but I want to just end off with this. We are taught to analyze body systems and parts separately and to change one area at a time. Such approach often ignores the interconnectedness of the systems in the human body. So we're coming back to this again. A couple decades ago with systemic, they became more popular and talked about. It's so important as to look at it from a holistic approach, and it gives us greater satisfaction in our practice. So thank you so much everyone for joining me on this Sunday morning. I will leave it up to the RF CBCT to also talk, and Darius from Synergy Specialist to say a few words, and then I could take any questions as well. Thank you.
Dr. Molayem, it was an excellent presentation. Thanks for sharing with us. And this is new for us. You're talking about IL-6, cytokine storm, and other things. I have lots and lots of interesting questions. Please stay with us. Don't go anywhere. Stay with us.
Sure.
At this time, I would like to bring in the co-founder of Synergy Specialist, Darius, and he'll be talking about the services, what they can offer, help the GPs. Darius, are you there? Welcome.
I'm here. Thank you so much, Dr. Prasad. Thanks, IDA. Thank you, Dr. Molayem. That was amazing. Some of you may have heard about Synergy Specialists. Others probably we may be working together. We're an agency that supports many practices nationally. We act as a matchmaker to set up specialists for in-house part-time specialty. Essentially, we help you guys work through the process of getting matched up with a pre-screened specialist part-time, all while we take the heavy lifting off of the practice's shoulders. What's great about our service offering is that we get paid through the specialist for finding these productive positions. So there's no cost to the practice owner for having us connect you guys as a match. And throughout the journey, we have some a la carte services that we add to the mix, such as credentialing and fee negotiations and what have you. The way it works is our specialist comes in 1 to 2 days a month. You line up a schedule to refer in the patient for that specialty treatment day. Typical arrangement looks like for surgical specialties such as perio, OS, and endo, they come in, they bring their own instruments, they bring their own equipment, while you supply the staff and the surgical sundries such as rotary files, 2x2 gauze, and you split the adjusted production 50-50. That's a little bit about Synergy Specialist. Now I wanted to share with you a little about our vision and how we are making strides and investing so much into education. Many of our specialists, we realized, are amazing educators, and they're willing to create unique educational CE courses such as this one today presented by Dr. Molayem. We're fortunate to springboard this platform with the IDA, but we're looking to team up with many other specialists within our ecosystem to bring quality content complementary. We feel by raising the awareness of the clinical trends, patient demands, and all the specialty related education, to name a few, that it will help serve our specialists to match them more with practices like your own, making their careers more productive while teaming up under one roof. If you're interested in bringing on board any type of specialist, especially a periodontist, to help implement the program Dr. Molayem spoke about today, please reach out to us and schedule some time to chat. Thanks again for your time, Dr. Molayem, and the IDA. That was really great. And I also just wanted to mention that we're going to email out a special offer to all of the IDA members. It's a $50 gift certificate to our PPE shop website. We understand how crucial it is to have the right PPE, and the supply chain is a bit broken still. So thank you so much for everything. Thank you, Dr. Prasad.
Darius, thank you very much. Thank you very much. And could you share your email address and also contact number for the doctors? We can post it on our chat box too. Please provide us the information.
Sure.
And we would like to invite Mr. Tim Torak. He's from RF America. They're also sponsored for this event. And Mr. Torak, all yours.
Thank you, Dr. Prasad. My name is Tim Todak. I'm the director of HDX Will, and we are essentially a CBCT manufacturer out of South Korea. And I wanted to kind of bring to you guys some information about CBCT, especially with looking at Dr. Molayem's discussion about being able to diagnose and look at issues associated with COVID-19 and periodontics, that being able to see the whole picture is really what CBCT is meant to do. So I'm going to kind of share my screen here a little bit. And we're going to kind of take a look at some ways in which we can do that. So now, what we're used to seeing in dentistry is usually the 2D image. So we're used to being able to view from either a bite wing or a periapical, or even the pano view of being able to see that. But what we end up being able to see is only 2 dimensions. We can't see the soft tissue interaction. We can't see, all we can do is diagnose the bone. So with the fact that when you get a CBCT, the CBCT allows you to be able to get that 3-dimensional look, to be able to look at your patients and be able to break down what their actual bone structure is and problems associated with it. So now with HDX Will, we have a way of being able to get very clear pictures and the ability to actually examine the whole face and head or even just the dentition. But the idea is that our field of view, or what we can see, is we can actually see the whole dentition. So now you can actually treat the whole patient as opposed to a small section, to be able to look at each part of the bone and be able to see what's going on. So now, in the process of this, that I always like to teach that, you know, the key to making an effective treatment plan is having complete knowledge of the problem. And also, the key to getting your treatment plan for acceptance is to have the patient have that understanding as well. So when you look at CBCT, CBCT is not only a great way for you to be able to create a deep understanding of what the bone and soft tissue interactions are, but that it's also a way to explain the patient. Because if you look at this image here, you can see that we can understand these cuts, but the patient's only going to understand this big skull model. So in this case, this patient, if we turn to the side here, actually you can see that as I blow this picture up, that they're able to see that they have some roots being exposed on the right-hand side, and that we can be able to give them a better idea as to what's going on and maybe what their treatment plan is associated with it by going through a story. So what we can do with our CBCT is, again, just as the first picture showed, is that I can actually superimpose their face over the 3D model and be able to say, this is you. Now let's go ahead and let's take a look at your bony structure, and let's try to start evaluating what's going on with you and the things that are going on. So we can move to our 3D diagnosis and be able to say that I can see that I see this little spot here where the root is erupting. So I'm going to go ahead and bring that back down, and let's take a look at that more closely. So now I can bring this picture down a little bit so we can examine it better. Turn our head forward and then be able to say, okay, well, that's on the right-hand side. So we're going to bring this down to where we can go on the right-hand side. So this is right. Bring it over and actually take a look at that area. We can actually create a tangential of that area, so that now what we can do is we can create a buccolingual view of our patient, so we can make it easier for us to examine that patient and be able to look at all the different things that's going on with that patient's anatomy in that area. So we can scan from, this would be lingual, and then going buccal all the way across. And as we go buccal, we're going to see that we see that tooth root just erupting right on the side here, as we saw in the 3D image as we looked at over here. So things we can do with this as well is we can kind of create even an endoscopic view of what that looks like as we look a little closer. Again, bringing a little bit more knowledge to ourselves and our patients. So we can create images in which we can kind of take a view in which we were flying into that area. And now we can actually show the patient and be able to say, so here's where that root is erupting from here. And so we're really curious about this area and seeing that is there a way in which we need either bone graft, or is there an infectious process going on in there? But this gives us an ability to be able to create that conversation and create a more adept conversation for our patients to understand. So now, in that sense, that with CBCT, you can create an STL file. An STL file is essentially either an intraoral scan or a CBCT of a stone model to create an overlap of where the soft tissue interaction is. So in this case, we've actually overlapped the intraoral scan on the CBCT. So now we can actually see where the soft tissue interacts with the bone itself. We can be able to take a look at it. Again, that also helps us in our diagnostic process, because now we can go through and we can actually look and see that little red line indicating where our soft tissue is on top of that, so we can actually take a look. So going over to the area where we had the issue before, and I'll scan across it, then now we can start to be able to evaluate this patient for being able to decide if we need to be able to do bone grafting. Is there an infectious process? So we're going to come along in here. I'm going to move this picture down just a tiny bit more. And then as we move closer and closer to that area, and we're going to see this is where that tooth has erupted on the outside of it. And that's what we saw before. Now, in this case, you can see this red line being the STL, or the soft tissue, that whoever did the scan for us didn't get all the way the soft tissue up into the gum line as well. But this little air pocket is a good indicator of the fact that there's where the cheek is, and this is where the gum line is across there. But again, if we had to go and decide about doing something like maybe bone grafting or what have you, now we have a better picture. We have a more complete picture of what we need to do for this patient to be able to make sure that we give them the proper treatment plan, and that we can be able to show them, this is where your soft tissue ends, this is where your bone begins, and what we can do with it. So just a quick little addition and introduction to CBCT. We have web series that kind of go through this a lot more in detail on how we can examine this further. And they are on our website. Our website is www.hdxwillna for North America.com, or you can contact RF America, and they'll be able to give you some information and direct you to how we can learn more about CCT and how it can help your practice.
Thank you very much. I do appreciate your time, and please stay back. We have questions for all three of you. Doctor, are you ready for the questions? The first question is IL-6 cytokine storm. There are two parts to this question. Please explain it again. How would you explain to the patients in their own language? What would be your language you're going to use with the patients?
Okay, that's a great question. So basically, going back to my first introduction, I talked about how bacteria enters into their gums, leaks through. We talk about also it's not really the bacteria that gets in as much. It's the toxins that get in. So I like to use the word toxins because those are great words also to use for cytokines. They're toxins causing toxicity, and there's a signal. And I say your body's soldiers, they come to attack. And I like to point, I like to get, animated, show them, like this. I'll say your body soldiers go to attack, and then they release a byproduct called IL-6. And this IL-6 is basically your body is a bad protein, a bad molecule that goes around and it spreads. And other areas in the body then start releasing it too. And there's a storm. So your body, for some people, this happens and it's not controlled. It just goes out of control, and this IL-6 and this toxins, they build up too much. So it becomes a storm. That's all I'll put it.
Good. The second question is, when you talk about reducing IL-6, you mentioned do a thorough cleaning. And
Yeah.
here is the problem we face. We cannot use the Cavitron because of the aerosol generation. What would you do at this time? Can we go ahead and, there are again two parts to this question. Would you recommend using the Cavitron hand instruments to clean the mouth? That's part number one. Part number two, would you recommend, you mentioned how do you pronounce it? Tocilizumab.
Yes.
And the Decodron. Can we kind of pre-medicate them, or can we put them on this medication to prevent further spread? So two parts.
Yeah.
We can on because of the aerosol generation. How would you kind of maintain the oral health, and can we put these two medications right away?
Okay. So I would buy some new scalers. Okay, because some of the ones that we have are probably not as sharp. So this one might be a good time to get some new scalers or sharpen the ones we have. Then for certain cases that I use Cavitron once in a while. Okay, so it's not like I never use it. When it's being used, it's someone that's in really bad shape, and I just need it, so it's pretty rare, but I do use it once in a blue moon. But other than that, I'm just numbing really well, hand instrumentation, and I tell the patient, I'm going to be putting a lot of pressure, and I'll just go and I'll scale it really well with either sharp or brand new scalers. Okay. if you do use a Cabochon, you got to obviously be very careful. Double mask, N95, face shield for you and your assistant. Try not to use that room for a couple of hours. You know, be more cautious. But and the second part to the question, you know, I'm not a medical doctor to know exactly when to be giving a arthritis medication or not. But having said that, you know, even medical doctors aren't doing it yet because this is all new research. Everything's developing, you know, every week. So I bring it up because it looks very promising. You know, when you see 90%, and you see the main problem is IL-6 and something is a IL-6 antagonist, it just makes sense to us. Why not? But what I've been doing is at my patients that do have arthritis or have borderline arthritis, I suggested them to talk to their doctor. I write down the name of this and I say, this is you know, great. It's the arthritis medication that's great for COVID. So if your doctor is able to give it to you and you're able to have it, this might be the one to be on right now. So they'll kind of take that information and go to their doctor, and they'll be the final answer on that.
Oh, okay. And would you suggest using the pre-rinse, chlorhexidine pre-rinse, or even hydrogen peroxide pre-rinse before we start any procedures? And what would be your pick?
For sure, I would do that. Every patient that comes into the office, and my offices that I go to, a good majority of them, the patient comes in, checks in, they take the temperature. Part of it is they just go to either the bathroom or if there's a sink in the hallway, and they already have everything ready, and they'll rinse with either hydrogen peroxide. That's probably a go-to, I would say. Chlorhexidine is not as good as good as hydrogen peroxide, but the best is if you get diluted iodine or betadine. That would be even better for COVID. But all of these things are reducing the bacterial load. So if there is, for example, an aerosol, there's less of the virus in there, which means they believe that COVID is based on the severity of COVID is also based on the load, the initial load of what gets in. So this will reduce that.
You also mentioned about bad breath. It's not from the tongue. It's mostly along the bone level. It collects along the bone.
Yeah.
What do you do? What would you recommend? How would you prevent?
So, you know, it's not that it's not on the tongue. There's less of it on the tongue. Most of the bad breath comes from the bacteria that release sulfur. That's the smell. It's the smell of sulfur. So, you know, obviously start with the SRP. Do some sort of, some chlorhexidine mouth rinse afterwards, and then they may need an osteosurgery. They may need an open flap and get deeper. You know, so and that's why in a lot of the offices I go to, we have a protocol. The SRP is done, and if they think there's some bone loss anywhere, it's an automatic reevaluation. We call it a bone check. So we do a bone check at 1 month after to evaluate and check there to see if it got better. If it didn't, it may mean that it's deeper in the bone, and so they may need deeper. My analogy is that
we lost you. Are you there, doctor? For some reason, we lost probably the internet connection. Darius, are you there still?
Yes, sir. I'm right here.
Oh, doctor is back. Doctor, can you hear me?
Yeah, I'm right here.
I mean, we lost you the last portion. Would you repeat the whole thing, please? We just, I don't know, might be your internet connection. We lost you.
Okay. So I was saying how the explanation I give is the periodontal pocket is like a swimming pool. Let's say they have a 6 millimeter pocket. It's like a 6 foot deep swimming pool, and the hygienist only has a 4.5 foot stick. So they can only get in, maybe they got the sides of the pool really well, but they're not getting the bottom of the pool. And that's the bottom of the pool is where it's spreading. So that's why sometimes they need the help of a flap where we lift the gum back gently and we can see and remove everything. Any tartar, any infection, any granulation tissue, any sources of bacteria. We put, at that time I put Peridex in there. After I scrape it all out, we smooth everything. That's what osseous is. We're smoothing, we're making it less craters, less places for bacteria to hide in there. And then sometimes we even put some bone powder to help make the bone stronger. So that's how I explain it to the patient. It makes sense. You know, you have a 6 foot deep something pool. You could only get in 4.5 feet. We have to go a little bit deeper. And so that's linked to the bad breath, because that's where the bacteria hang out. And also remember the chart I showed of the bacteria, that the bad bacteria, the red, the orange, and the green. With every millimeter deeper you go, the different colors increase. So the green one might be 4 to 5 millimeter pockets. Then the other one's 5 to 6 millimeter pockets, and the other one's like 7 and up. You know, so that there's been a relationship between the depth and the severity and the pathogenicity of the bacteria.
Okay.
And then, of course, those are the ones, the bad bacteria are the ones that release the bad breath, the deeper ones.
Doctor, don't go anywhere. I'm going to switch the gate to Darius. There is a question for him. Darius, the question is, who is responsible to add the specialist name to the plan? Do we issue 1099 to synergistic specialist?
So I think those are two separate questions, right? One related to the credentialing and second related to how the payment workflow would work.
Second one, in terms of issuing 1099, whom are you going to issue to? Is it to the doctor or it goes to the synergetic specialist?
Right. So all of the specialists are considered independent contractors of the practice. Many of the surgical specialties in California are independent contractors of our own professional corporation. So essentially, we would contract our PC with the practice owner, and you would issue our professional corp a 1099 at the end of the year. That's for the surgical specialties in California. Ortho and pedo, ortho works differently, where you treat the orthodontist directly as an independent contractor. And as far as the credentialing, we realize this is a challenge for most office managers to fill out hundreds of pages worth of credentialing apps and follow up with insurances. So we have a whole department that handles all this to, obtain the specialty fees that would be accurately reflected. I could go a little bit more into the process if you like, but we would handle the credentialing.
Yeah, could you go through quickly, Darius, what the process, what is it entitled? If you can make it short.
Sure. So first we figure out what specialist fits your practice. Once you meet with the specialist, we get involved to help with the preparation phase, which part of it involves the insurance credentialing. We would ask you which insurances you would like the specialist to go in network with, and then we would begin processing the applications to the insurances to obtain the specialty fee schedules. PPOs can take anywhere from 1 to 3 months. HMOs can take anywhere from 2 to 6 months to come through. A lot of our oral surgeons, by the way, also accept Denti-Cal, by the way. And after the insurances start trickling in, the fee schedules, we work off of the adjusted production until all of the fee schedules are in order and thereafter.
Okay, thank you. Mr. Todak, question for you. CBCT, who manufactures that, the company's name, and how much would it cost?
So our CBCT is manufactured in South Korea. Our company is called HDX Will. We've been doing CBCT for about 17 to 18 years now. We just went global in 2017. And so we have our own offices in North America. Our North American branch has our central office in Los Angeles, California. And then we have branches all across the United States. And then as far as pricing is concerned, I'm going to refer that over to RF America. Since RF America is one of our dealers, that I'll let them go ahead and talk about all the pricing. If you have any questions about the actual machine itself or its functions, I'm more than happy to answer with my email or through RF America as well. We can set up a web conference so I can go through and see exactly what we can do to help you with your practice.
Thank you. Thank you. Darius, one of the doctors would like to have your email address. If you can post it, please, with your contact information. Okay, doctor, moving on with the questions. Could you briefly touch upon the protocol to maintain periodontal health of our patients?
Yes. So is this at home for the patient or for us in the office?
How about both?
Okay. So first of all, let's talk about at home. Brushing twice a day, 2 minutes at least. So 30 seconds per area. I like electric better. Obviously, the older they get, I recommend electric for sure because it's easier for them rather than moving it so much. Flossing twice a day, preferably they can after meals. When they floss, again, a lot of patients ask, should I floss first or brush first? I get that a lot. I always say it doesn't matter as long as you're doing both. They shouldn't get caught up in which one because it really doesn't make a huge difference as long as they're doing both. But let's say they floss first, then they brush. Then I've noticed from talking to patients, most patients don't know how to floss. So they'll just take this and go like that. And the papilla is a V. So imagine you just go and you take this and you go down and you end up cutting and damaging the papilla. If it's inflamed, then it bleeds, not from, you got to go in this direction and then you got to go in that direction. So that's why you want to wrap around like a C shape this way and like a C shape that way and then pull it out. So you have to do that around every tooth. So you go like this, go like that, out, in, this way, so that you can actually get deeper. You don't want to just stop right there. You want to actually wrap around and go a little bit deeper. Okay, so that's at home. Chlorhexidine, obviously you don't want to. If you give it to your patients, you want to give it to them for like a week or two. You don't want them to use it too much. They could stain their teeth, mess up with their taste buds, cause a black tongue. I'm a big believer in the water pick. So I recommend all my patients to get it, especially the older ones, and especially the ones that have spaces between their teeth. And but water pick is great. The trick with the water pick is if they could put some hydrogen peroxide and mix it in with the water. And they usually ask me how much hydrogen peroxide to put in. I like about 1/3 peroxide, 2/3 water. And every night, that will be the last thing they do. So after they brush, they floss, and then they'll go with a water pick. That's their final thing I like to do. I don't like for them to even rinse their mouth with water after it, because I want that hydrogen peroxide residue to stay in on their gums and on their teeth, because it's shown to be protective the first few hours of sleep, that the bacteria don't even like to sit onto the teeth, the plaque. They don't like to, there's all this plaque hanging around. They don't like to sit down. That's why when you wake up in the morning, and I tell patients, you go like that, everyone has white stuff. That's the plaque, that's the biofilm. It's collecting this bacteria in there. So the water pick, the residue with the peroxide, it stops that from colonizing the first few hours of sleep. And remember, it's during sleep that when our mouth is dry, and if we're a mouth breather, our mouth is dry, and that's when these bacteria really go to town. So that's when you want to be protected. And if they're wearing a night guard, or if they have a retainer, then it's just more of a harbor for that bacteria. Now, when they come to the are really good. There was the European 11th annual European. They have a consensus meeting. It's not an annual. It's just a consensus that the periodontists meet. They even showed that it's almost as effective as flossing. So they're recommending interdental brushes, especially for people who have more spaces and it will fit through. At the office.
Again, we lost you, doctor. Are you there?
With prophies, I would get in. I would really, prophy just means you're in a way that prophy, it means you're just shining their teeth in a way. So you want to get in, you want to scale, okay? There's a difference between scale and root planing. Scaling is below that. So you don't root plane people if you can't get through. So go to the 4 to 5 root plane. You might have to numb even. And patients appreciate it. If you numb, they don't get upset. You say, I really want to get in, and I'm not messing, I don't want to mess around. I want to make sure you have less inflammation. I want to, numb you. They'll appreciate it. And you go in and you scrape, do some root planing. Again, you're not going to root plane this area over here most of the time. It's most of the time in the back. And then again, I like to, actually floss their teeth for them, to show them how to floss. Get the mirror for them so they can see what you're doing. Then hand them the mirror, hand them the floss. You hold the mirror. You watch them do it. If you teach someone how to floss and they don't floss themselves right in front of you, the chances that they go do it are much less. You don't have to do this. Your staff can do this. Your hygienists can do this, or your assistants can do this. It's a good thing to show them. And all of this brings value for the office.
Doctor, the next question is kind of might be a little bit tricky. At what point we GPs, we had to refer the patient to periodontist? Can you hear me?
Anytime there's a 5 millimeter pocket or more, yes, I can hear you. Could you hear me?
Yes, go ahead.
Okay. Anytime that there's a pocket after scaling and root planing, I would so some offices are a little bit more on top of it. They'll do SRP, and if the patient is on the older side, they'll say, let's do a reevaluation with the periodontist to see if those 5 or 6 millimeter pockets are better. Again, the people who are still listening right now, you will be surprised what I find. Remember, when we probe, we're not looking for furcations. The furcation behind number 3. Remember, this is a 3-rooted tooth.
Mm-hmm.
Okay? The distal, I get in there. If you do a probe like this, yeah, you're going to get 3, 4, 5 millimeters. Okay? Don't forget, get your probe sometimes and go in. It drops in, the patient goes out, blood comes out. This the distal of number 2, the mesial, all that area. You have to check that area. They get headaches. They get the ear problems sometimes. It digs a hole. This is IL-6. This is bone loss. This is advanced periodontitis. It's happening. And I like how the cone beam conversation came up, because that's a beautiful tool, as you can see from the cone beam, that you can see so much of what's happening in people's mouths by rotating the cone beam. You can see, he showed that one angle where you can see the roots. Again, that we can't see it. We need to use technology sometimes to see it. So cone beam is definitely the future. I think every office should have one, and in the future will.
Same token, doctor, would you recommend we order CBCT before starting any periodontal treatment?
It's not a bad idea. Again, if you have one, I mean, I would say if it's it's a tricky question, because you don't want overkill either. If it's a part of it, some offices protocol is every patient gets a CBCT, and then they look at that root canal and they see, oh my God, when they look at the cross section, they see there's a lesion there.
Mm-hmm.
There's a whole nother world that we're not seeing, that we could be seeing. And since I'm in that world where I look at CBCTs more than the average dentist, I find things that, like the root canal specialist, I think all root canal specialists should be using it, and not all of them do. There's cracks, there's lesions, there's lateral canals that were missed. There's so much going on underneath.
Okay, thank you, doctor. Darius, are you there?
Yes, sir.
Again, going back, if you can help our doctors in the sense, in terms of bringing the periodontist to our office, what is the protocol we should follow, and how can we start the process going?
First step, reach out to us. Let's have a discussion about how this all works. But generally speaking, you got to meet with the periodontist that we would introduce to you. Periodontist would come to your practice. There's no obligation or commitment to register with us. We just want to know if your chairs are left-handed or right-handed, how many hygienists do you have, if any at all right now. And that way we can kind of identify the best match as far as a periodontist. Because we have many periodontists in California, and almost all of them have had discussions with Dr. Molayem from a sense of clinical leadership on our part, and they're on board with this sort of program should the practice owner want to implement it. I always tell all the practice owners and specialists it's within their comfort level and clinical philosophy of matching up, which is really what we do best, is succeeding with these long-term matches. Periodontist is looking forward to coming in long-term. This is something that they look at as part of their career, not just something like short-term. Most of the practice owners that reach out to us, they're new at setting up a specialty. And, there's a lot to dive into the weeds as far as the preparation is concerned, but generally speaking, the first step is reach out to us so we could get you introduced to a periodontist so you guys can meet, and we'll guide you through the process from there forth.
We lost your audio. Can you repeat it?
I'm going to turn off my video so it doesn't take up the bandwidth. Hope that's okay. Can you hear me now?
Yeah, go ahead. Go ahead.
Yeah. Which part should I repeat?
The last portion. We
Yeah,
missed out.
generally the first step would be to reach out to us so we could get the periodontist introduced to your practice and come by to meet with you on a scheduled time block. I could post the practice application link or email it to you guys as a follow-up, and we'll reach out to you to go over the whole program. It's like a 15-20 minute phone call that we call an introductory call. And yeah, generally speaking, after you meet with the periodontist, you usually schedule the first treatment day like 60 days out. That way it gives us enough time to, handle credentialing most of the insurances, setting up a training with your front office as far as like billing and consent forms and what have you. The 2 months that it takes for us to prepare is a good enough time also to line up the initial day for consults. And then once you get into the groove of things, your office manager and you start basically, quote unquote, converting these cases before the periodontist even comes in. But initially, it's all about just engagements. You have to engage the periodontist, meet with them at the practice, and then we have to start having consults with patients that would be proper candidates.
Okay, there is one more question popped up. Other than 50% share, are there any other contract or other fees?
Yeah, there would be a contract. You would need it in case of an audit. You have to justify everything, especially as an independent contractor. The matching is very straightforward. You call us, we get to know your practice, we get paid through the specialist. There's no fee to the practice owner. We do offer other a la carte services that, for example, credentialing, where we charge it as a bundle package. So if you told us you want to do every PPO under the sun that you carry, we charge a flat rate of $1,100. If you wanted all the HMOs and PPOs as a bundle, we charge a flat rate of $1,600. And essentially, that process would save your office manager many hours. Most practice owners go with us. The far majority, like 90%, end up doing credentialing with us because, we have the specialist documents on file. We're in touch with like all the insurances. We do it fairly quickly and accurately. Part of the process of credentialing entails us doing a fee analysis, in which case we would pull up the national, the NCDS book, which is the national codes of where the percentiles lay for every code that's billed out there. And we'll run a report for that zip code of the practice and tell you where all the specialty fees run as 95th percentile, 90th percentile, and so forth. That'll give you and the specialist a bit of a compass to work off of, and also for us to be able to have negotiation power when we're credentialing to obtain the specialty fees.
Okay, one more question popped up too. Is there any minimum production needed per day?
Every specialist has some sort of production goal in mind. We do a good job of outlining that. Generally speaking, the further out the specialist has to drive and the higher in demand that specialist is for that region, then yes, the production levels are higher expectation. I'll give you an example. It's very hard to find a local endodontist for Turlock, California, which is in Central California. So most of our endodontists fly up there. The only reason they go up there is because there's practices willing to line up full days with 8 RCTs and bill fee for service, for example. But the majority of the practices we like to match up are within like a 30-minute, 60-minute driving radius of the specialist's residence. So it's more sustainable that way. You figure for perio, you really don't need more than like a few cases lined up to average 6,000 to 8,000 in total production per day. A periodontist can do that in the morning. Dr. Molayem will tell you. Average productions tend to be a lot higher than that, but most of our periodontists are happy to do a production goal of, let's say, 6,000 to 8,000 a day. They're looking for consistency. That's the key with all this, is consistency.
Yeah, so if I could chime in, usually we'll do set up our days once a month. We'll give 6 months or 4 months in advance, and then we like to drive usually up to about an hour. Right now, which is less traffic, so it's really good. Production-wise, I would say, we're again, consistency is very important, as Darius said, but we are looking for somewhere around at least $8,000 of production, which is, a couple of quads of osseous surgery, maybe an extraction bone graft membrane, maybe 1 or 2 of those, and then like an implant. So it's pretty pretty easy to get to that number. Each quadrant of osseous is usually, let's say, like anywhere from 1,300 to 1,500. Each implant, that depends on the implant how much you guys charge. But yeah, if we can fill up the schedule as much as possible, consultations, setting the expectations for the patient. Our specialist is only here once a month, so if you need any treatment, he sets time for getting it done the same day. So that they're not like, oh no, I there's no way I can do it today. So some people you schedule, some people, if it's something urgent, then they can do it that same day. There's no problem.
Thank you, doctor. I think it's already 12:15. I'm going to go with the last 2 questions. And doctors, if you have questions, please email it to us and we'll pass it on to the specialist. The question for you, doctor, how much this oral genetic testing charge, DNA testing charge, and there is one more part to that. Would the health insurance cover it? And the third part is it FDA approved?
So it costs about $115, $120. Then you have to do, the shipping is usually free. So they charge, depending, you might be able to get, if you do so many, then they'll give you a deal. So if your office gets on a good program, then they could drop it down a little bit. But there's multiple tests that can be done. So you can do the IL-6, you can check bacteria, you could check for cavity bacteria. So if you see someone's getting a lot of caries, they can check for that. And each of these tests, will add on a little bit. I think for $200, you can pretty much do almost every test. By the way, you can do COVID tests too. So there's a special, the same lab, they send you another kit that you put in it for the nose. That one you have to ship overnight, and then within 24 hours they'll give you a result. So you guys can do COVID testing if you want as well with them.
Oh,
I've used them. And they emailed me results.
Yeah. What is the company, doctor? Do you have any information on that?
Yeah, it's called Oral DNA Lab. You can Google it. The phone number. Create an account. They send you test kits. They send it to you for free. So if anyone can call them, set up an account, call and say, even online, you go and click, and they'll send you 10 free COVID tests and 10 free kits.
Oh,
it's not a bad thing to have in your office. Yeah, I've been doing COVID testing for some of my family.
Huh. I would ask the last 2 questions for you, doctor. Are there any materials available that can help dentists educate their patient to maintain their oral health during this time?
Materials, like as in like
maybe like something like a brochure or whatever it is, where we can order it.
In particular to what I mentioned, or in general?
Particular to what you mentioned. Yes.
Yeah. So I think I will create an email that they can send to their patients. I think that's there's a new article that's been published in the California Dental Association this past week, that says da 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 da, and so it will basically get them interested to come in. I think that's what you want. You want them to come in. These are people that haven't been, they haven't been to the dental office for a long time. So and it'll explain, and it will be very general, just explanation of what I'm talking about, what I talked about, and then you can follow it up by explaining it a little bit more when they come in. I think that would be more effective.
Last question, and I said, doctors, if you still have question, email it to us, and I will definitely pass it on to the specialist. The last question being, could you reduce IL-6 by treating patients with PerioProtect treatment?
Yeah, that's one way of doing it as well. Probably for someone who, I would do it in conjunction with like a scaling and root planing. So I wouldn't just only do PerioProtect. But yeah, I think that's, I would say it would be helpful.
Would you quickly run the protocol there?
Basically, you make a tray, and the PerioProtect is you're injecting the solution in there, or gel that they wear, and it basically seeps through the first couple of millimeters into the gum to kill the bacteria and decrease inflammation. So you look at like the before and after of a lot of their the cases that they have on their website. I just saw one the other day actually. The redness kind of calms down, and it's something that they can do at home, overnight. So I would say it's definitely helpful. It wouldn't hurt, and it's not for the very severe cases. You don't want to do for more severe situations. You don't want to do something that's not gonna get to the root of it, because you give them the false sense that this is going to cure them, and you're doing them a disadvantage.
Thank you, Dr. Molayem. Thank you very much. You certainly shared a lot of information with us, and we'll love to get you back one more time. And if you can post your email address, that would be wonderful for the doctors.
Yeah.
Darius, thank you very much. So do Mr. Torak. Thanks a lot. We'll be seeing you all in about a couple weeks. Have a great rest of the week. Thank you.
Bye-bye, everyone. Thank you.
Bye-bye.
Thank you so much. Bye-bye.